An amiable welcome to everyone. This is our Lecdem channel to enhance your understanding. Today's topic is about endotracheal tube. This is a picture of a person who has been intubated with an endotracheal tube. An endotracheal intubation is a placement of a tube in the trachea to facilitate intubation. ET tubes are curved tube. They have two ends, proximal end, which is the machine end, and a distal end, which is the patient's end. The ET tubes may be cuffed or uncuffed. Tubes are previously made up of lattice and still available. Currently, plastic tubes are preferred. Polyvinyl chloride tube advantages. They are disposable. They are transparent, hence the buildup of blood or pus in the tube which can cause blockage can be visualized clearly and less chances of causing any allergic reaction. Endotracheal tube components. An ET tube has a patient end, a machine end, and a Murphy's eye, and a cuff, an inflating tube, and a tube connector. When the pilot balloon is inflated, the cuff which is present at the patient end also get inflated, which will prevent aspiration of any gastric content into the airway. The central portion, a vocal cord guide which should be placed at the level of opening of the vocal cords so that the tip of the ET tube is positioned above the bifurcation. A radio opaque marker which is essential for accurate visualization of the position of the ET tube within the trachea by means of an X-ray. The distance indicator, which is marked in centimeter in the tube, facilitates the placement of an ET tube. A cuff in case of cuffed ET tube. The distal end. It has a Murphy eye which prevents complete blockage of ET tube in case the distal end is impacted with secretion and blood. The patient end is beveled with an angle of 45 degree in oral tubes and 30 degree in nasal tubes. Types of endotracheal tube. Endotracheal tube can be cuffed or uncuffed. In the picture, you can see a balloon-like structure at the end of the tube, which is the patient end. So one tube has a cuff and the next tube doesn't have a cuff. In this picture, you can see cuffed tubes. So when the pilot balloon is inflated with a syringe full of air, the cuff at the end, which is the patient end, will also get inflated, providing a tight seal, hence aspiration is not so possible. Cuffed tubes. Used in children lesser than 8 years of old, the cuff, when inflated, maintains the ET tube in proper position and prevent aspiration of contents from the GI tract into the respiratory tract. Uncuffed tubes used in children lesser than 8 years, pediatrics, because the narrow supraglottic airway forms the function of a cuff and prevents the ET tube from slipping. Which means that in pediatric patient, the airway are very constricted, so you don't need a cuffed tube to prevent any aspiration, and because of their narrow airway, the tube will not be slipping into the patient. Indication of intubation: to secure airway, to supply oxygen, general anesthesia, cardiopulmonary resuscitation, ventilatory therapy in ICU. Technique of intubation: the patient should lie in supine. There should be extension at atlanto-occipital joint and flexion at cervical spine. This position is achieved by putting a 5 to 8 centimeter thick pillow under the occiput. The laryngoscope blade should be inserted from right side of the mouth and advanced slowly, displacing the tongue to the left until epiglottis is visualized. This is a picture when an ET tube is inserted into your airway. Once the epiglottis is visualized, it is lifted anteriorly to visualize the glottis. Once the glottis is seen, the endotracheal tube is passed between the cords. The cuff is inflated and the cuff should be well below local cords in adults. The position of the tube is verified by capnography and auscultation over the chest for air entry. The tube should be well secured at the angle of the mouth with adhesive tape or bandage. Deciding the size of ET tube. For a normal healthy male, it is usually 8.5. For a normal healthy female, it is 7.5. Smallest size of tube available is 2.5 and the largest is 10.5 millimeter. So the formula used to calculate the size of tube for 1 to 6 years of age is age divided by 3 plus 3.5. For children greater than 6 years, it is age divided by 4 plus 4.5. Deciding the length of tube. Optimal length is the length at which air entry is equal on both sides of the chest. Usually it is 23 centimeters in adult male and 21 centimeter in adult female. Tip of the tube should lie 4 to 5 km above the carina. A carina is a cartilaginous ring within the trachea. In children, the length of the oral tube is calculated by the formula age divided by 2 plus 12 centimeter. Size of the tube. For the patient ranging from 0 to 1 years of old, we use 2.5 to 3.3 mm, and for 1 to 3 years we use 4 to 5 mm, and for 4 to 6 years we use 5 to 6 mm, and for 6 to 10 years it is 6 to 7 mm, which is cuffed, and for adult female it is 7 to 8 mm, and for adult male it is 8 to 9 mm. Uses of endotracheal tube. For mechanical ventilation, for intermittent positive pressure ventilation, during resuscitation, direct suctioning of the trachea, in epiglottis and life-threatening croup, in tetanus, in diphtheria and edema. Drug delivered by ET tube. Rate of administration of drug from endotracheal route are almost similar to the intravenous route. During CPR, drugs which can be delivered by ET route are adrenaline, atropine, lignocaine, naloxone. Complications of endotracheal tube. Mechanical trauma to tongue, teeth, palate, pharynx and larynx. Stimulation of posterior pharyngeal wall leading to coughing, vomiting, pneumothorax. Prolonged intubation may cause pressure necrosis of laryngeal structures, leading to persistent hoarseness of voice. Sore throat, leakage of the ET tube, tube in esophagus or one lung intubation. Extubation, which is the process of removal of the ET tube. Give oxygen for few minutes, which is called pre-oxygenation. Then insert a new sterile suction catheter inside the tube. Have the patient inhale. At peak inspiration, remove the tube. Suction the airway through the tube as it is pulled out. Extubation is the final step in liberating a patient from mechanical ventilation. MAGILL forceps. So this is a forceps which we use to clamp the ET tube sometimes. They are available in different sizes. MAGILL forceps. MAGILL forceps are angled forceps used to guide an endotracheal tube into the larynx or a nasogastric tube into the esophagus under direct vision. They are also used to remove foreign bodies. Thank you.